Imagine waking up with tingling in your toes. Within days, you're too weak to walk. Paralysis threatens your ability to breathe. This is the reality for thousands hit by Guillain-Barré Syndrome, a rare neurological emergency. Today, we unravel the mystery of Guillain-Barré Syndrome, from its triggers to life-saving treatments. Guillain-Barré Syndrome is an autoimmune disorder where the body's defenses mistakenly attack the peripheral nerves. Think of it as friendly fire. Antibodies destroy the nerve's insulation, myelin sheath, or the nerves themselves, disrupting signals between the brain and muscles. The culprit is often molecular mimicry. Molecular mimicry is defined as similar structures shared by molecules from dissimilar genes or by their protein products. Pathogens like Campylobacter jejuni, a common cause of food poisoning, share proteins with nerve cells, tricking the immune system into friendly fire. This destroys myelin sheaths or even nerve axons, halting signal transmission. A 27-year-old man comes to his physician complaining of a tingling sensation in his toes and progressive weakness in both legs. On questioning, he says that he had bloody diarrhea, nausea, vomiting, and cramps 3 weeks ago that lasted for a few days. He also complains of back pain. He has not traveled recently and has not eaten anything out of the ordinary. Physical examination reveals markedly decreased patellar and Achilles tendon reflexes bilaterally. What is the most likely diagnosis? The most likely diagnosis is Guillain-Barré Syndrome, or acute inflammatory demyelinating polyradiculoneuropathy. Guillain-Barré Syndrome is characterized by symmetric, ascending muscle weakness or paralysis that begins in the lower extremities. Hyporeflexia or aeroflexia is invariable but may not be present early in the course of disease. What physical findings are commonly associated with Guillain-Barré Syndrome? Findings in Guillain-Barré Syndrome include ascending paresthesias, cranial nerve deficits leading to dysphagia, difficulty swallowing, dysarthria, difficulty speaking, facial weakness, papilledema, autonomic dysfunction, and respiratory muscle paralysis in extreme cases. The figure shows papilledema of the optic nerve head in Guillain-Barré Syndrome along with the vascular congestion and elevation of the nerve head, and blurred disc margins, often seen in papilledema, papillitis, and compressive lesions of the optic nerve. Hyporeflexia is also commonly seen. In what settings does Guillain-Barré Syndrome usually occur? Guillain-Barré Syndrome often occurs 1 to 3 weeks after a gastrointestinal or upper respiratory tract infection, vaccination, or allergic reaction. Common associated infections include bacteria, Campylobacter jejuni, and herpesvirus. Although a preceding event is present in most patients, approximately 1/3 of patients with Guillain-Barré Syndrome report no such events during the preceding 1 to 4 weeks. What is the etiology of Guillain-Barré Syndrome? Guillain-Barré Syndrome is thought to be an autoimmune reaction that develops in response to a previous infection or other medical condition. This process results in aberrant demyelination of peripheral nerves and ventral motor nerve roots. Cranial nerve roots can also be affected. One may also see autonomic dysregulation, such as arrhythmias, hypotension, or hypertension. What laboratory finding is likely in Guillain-Barré Syndrome? Cerebrospinal fluid reveals a markedly elevated protein concentration with a normal cell count, commonly referred to as albuminocytologic dissociation. This contrasts to the increased cell counts typical of central nervous system infection. Increased cerebrospinal fluid protein can lead to papilledema and increased intracranial pressure. What is the treatment for Guillain-Barré Syndrome? The first element of Guillain-Barré Syndrome management is supportive care and treatment of the underlying condition with either intravenous immunoglobulin or plasmapheresis. Plasmapheresis is a broad range of procedures in which extracorporeal separation of blood components results in a filtered plasma product. In Guillain-Barré Syndrome, plasmapheresis filters out the antibodies in plasma that are attacking the immune system. Pulmonary function should be monitored with peak flow studies to assess for respiratory failure. Rehabilitation may be required to restore function. If this patient's symptoms worsen over the next few months with no signs of improvement, what alternative diagnosis should be considered? Chronic inflammatory demyelinating polyradiculopathy is a chronic progressive counterpart of Guillain-Barré syndrome that often presents with similar symptoms.